to welcome you to the webinar Prescribing for Perimenopause and Menopause presented by WellFemme, and I'm thrilled to introduce to you our presenters for this evening. We have Dr. Kelly Teagle and Dr. Lynda Newman. Now, Dr. Teagle, she really blundered her way into early menopause at age 42, and this experience really inspired her to help other women through this transition by creating WellFemme, the telehealth menopause clinic. I'm pleased to welcome Dr. Kelly Teagle. Welcome, Kelly. How are you?
Thanks a lot, Michelle. I'm absolutely thrilled to see so many people from so many different places who are watching tonight. So thanks a lot. I've been seeing patients today and I know how hard it is to drag your poor brain along to something else, but we really appreciate you joining us.
Absolutely. And our second presenter this evening is Dr. Lynda Newman. And Lynda worked in emergency medicine for 14 years, but a serious illness in 2015 led her to return to general practice, where she focuses on two ends of the medical spectrum: complex chronic medical conditions and also preventive medicine. Now, it's the preventive medicine that really led Lynda to her interest in helping women with menopause. Thank you so much, Lynda, for joining us. How are you this evening?
Thanks, Michelle. I'm good, thanks. So looking forward to our presentation.
Excellent. Now, Kelly, last week we ran a session which was a patient education webinar, and we had hundreds of women from across Australia attending that event. And the one thing that was really very obvious that came through from the feedback that we had was that often women just can't find the help that they need to help them through this menopausal transition. It was very obvious, wasn't it?
Yeah, it was.
Yeah. What can we do about this problem?
Well, we're doing something really powerful about it right now, which is to make sure that, we're all up with the latest in what we should be doing to help manage our patients' menopause symptoms. And so that's a really good cue in to just get right on into the presentation, I think, Michelle.
Fantastic.
Yeah. So this is our seminar. Unfortunately, Dr. Kent hasn't been able to join us. There's a very sudden internet outage in her area in Wollongong right now. So she's going to see if she can join us along the way. But if not, we will push on without her. So, yes, I'm very proud to be able to present this topic tonight on prescribing for perimenopause and menopause. And the reason, of course, as you said just then, Michelle, is the fact that perimenopausal and menopausal women are not getting the help they need for their symptoms. If they were, then I think I'd be out of a job with WellFemme. So it's there's a lot of reasons for this. A lot of women are in rural and remote areas. They don't have good access to doctors, or their doctors are not feeling very confident about treating their menopausal symptoms, or they have fears about whether or not HRT is safe for them. So that's what we're here for tonight, to talk about those things and to make sure that we're offering the right kind of information so that women do know what the effective options for their menopausal symptoms will be. So this evening, what we're going to do is review the definitions and diagnoses of perimenopause and menopause. We're going to describe the hormonal changes that are occurring, and Lynda's going to take us through all of that. Then we're going to launch into a bit of a summary about what the latest evidence is telling us about the safety of MHT and the best practice approach that we like to take at WellFemme when we're prescribing MHT. And we're also going to present a few case examples just to put it in real life context for the sort of patients who might come to you with symptoms. So without further ado, I'm going to call on my learned colleague, Lynda, and she's going to take us through the definitions of menopause and perimenopause and a little bit about the changes that are occurring at that time.
Okay, so thanks for joining us. So I'm going to go through the definitions, the hormonal changes and their diagnosis of menopause. It's important, I think, to understand the hormonal changes because that reflects on the diagnosis and then correctly choosing the most appropriate intervention or treatment. So we'll start with definitions. So menopause is the permanent cessation of menstruation, and natural menopause is said to have occurred to have occurred after 12 consecutive months of amenorrhea, and as such, it's a retrospective diagnosis. The usual age for menopause is 45 or older. That's a normal menopausal age, and the average age for an Australian woman to reach menopause is 51. Then you've got perimenopause, which is the period beginning with the biologic, clinical, and endocrine changes that occur running up to actual menopause. And those changes start to occur from about, up to about 10 years prior to menopause, which is when your final menstrual period is. Early menopause is menopause occurring between the ages of 40 and 45, and that affects is applicable to 10% of women. So 10% of women have an early menopause. Premature ovarian insufficiency is menopause occurring at an age less than 40, and that affects 1% of women. Then you've got induced wet menopause. I'm just going to try and use the arrow. I think you might be able to see that. Induced menopause, which is menopause caused by surgery, so bilateral oophorectomy or radiotherapy, chemotherapy, or any medications that you use. And your postmenopausal, after you've had you have a diagnosis. It's anything after your last period is postmenopausal, but you don't know that you're postmenopausal until 12 months after your last period. So I just did want to show you the straw plus 10 criteria, because that's we use that quite a bit in menopausal medicine. So STRAW stands for the Stages of Reproductive Aging in Women, and was derived by a group of an international group who were trying to sort of quantify the stages of reproductive aging. So what I want you to do, since the arrow is not working, I'll just try again, is look at the little red line where you've got your final menstrual period. And then if you look at the little blue dot, which is the end of perimenopause, you can see that perimenopause overlaps menopause by a year, which is the nature of that retrospective diagnosis. It's very confusing. And then the other thing that's handy to look at with the STRAW criteria is if you see the little green dots, you can see that perimenopause is divided into the early perimenopausal transition and the late perimenopausal transition. And that's also useful to know when you're trying to tailor treatment to each woman, to the individual woman. So next we're going to have a look at the hormonal changes that occur with menopause. So if we understand the hormonal changes, again, it helps us tailor the treatment. So we're going to have a quick look at the hypothalamic pituitary ovarian axis, and then we're also going to have a look at the menstrual cycle and just see how these two relate to each other. So firstly, if we look, this is probably familiar to a lot of you. So just a reminder, so you've got your, well, no, I don't need it because the arrows are there. So you've got your hypothalamus producing gonadotrophic releasing hormone, stimulating the pituitary to produce LH and FSH, stimulating the ovary to produce estrogen and progesterone, and then you've got feedback loops going backwards. So when your progesterone or estrogen drops, you don't get the feedback to the pituitary, so your FSH rises. So it's just handy to kind of remember that feedback loop. And then the second one is if you look at the normal menstrual cycle, there are just two things you need to remember in menopause and perimenopause medicine. And that is that the first half of the cycle, under the influence of estrogen, the lining of the uterus, it proliferates. So it's the follicular phase. So the lining of the womb builds up under the influence of estrogen. Then you ovulate, produce the corpus luteum, which produces progesterone, and the lining of the endometrial lining, that's a better choice of words, stabilizes. And then when the corpus luteum dies, the lining comes away, and that's your period. So what happens around the perimenopausal time is you're not getting good quality eggs, and you're not ovulating, and you're not getting good quality corpus luteum. So you're not producing that that progesterone to stabilize your endometrium. So I explained to the women when you're trying to explain the heavy periods that you know, the lining of your womb builds up, and then you don't ovulate, or it's a poor quality egg, and then the lining of your womb just continues to build up, and then you get these horrible, heavy, clotty periods. So to get a nice regular period, you need lining of your endometrium to build up, you need it to stabilize, and you need it to come away. That's what's missing in the perimenopausal time. And then the third little bit of hormonal change that I find is helpful to understand, again, with respect to understanding symptoms and with respect to targeting treatment, is that the phases of estrogen and progesterone in the reproductive cycle. So as a child, you have low estrogen and progesterone. I'm just going to ask Michelle again if you can still see my arrow, because I've got no concept of whether you can or can't. Okay, great. Then as a reproductive woman, your estrogen goes up and down, just varies a little bit, but stays pretty high. Your progesterone is, of course, going up and down with each cycle, so as you go through the follicular and then the luteal phase. Then in the perimenopausal area, which is the area that we start to look at, you've got your estrogen fluctuating a lot. So early perimenopausal time, it's going up and down quite a lot, and we say wildly is the word we use, with a trend downwards until when you're postmenopausal, it's quite low. But if you look at your progesterone, when you stop ovulating where you've got poor quality eggs, your progesterone just drops right down, kaboom. Then you have your odd ovulation, it goes up, but by and large, your progesterone's low or gone, and that causes a separate set of issues. So I think it's just handy to know that estrogen is varying and progesterone might have a few spikes, but by and large, it's gone. Okay. So then that leads us into the diagnosis of perimenopause and menopause. So the first thing that the menopause sort of doctors are very mindful of, that the diagnosis is clinical. So a lot of women, they think there's something wrong with their hormones, they know, and they want their hormones measured. But if you go back to that slide there, that's great, you'll see that there's you can catch the hormones at any level. So by and large, we try and avoid measuring hormonal levels. It's just not helpful, and it can cause a lot of confusion. So what you need to do is you need to take a good menstrual history, and you need to get a good history of menopausal symptoms to get your diagnosis.
Sorry, just to interrupt there, Linda, because we've had a question from someone called Tracy there about having had a hysterectomy but still having their ovaries, and so there's no actual finishing of the periods. And I think that's really important in the context of what you're talking about here, isn't it? Because, you know, it's not really helpful to be measuring the blood tests, and whether or not we do anything really relies on symptoms in this space, right, rather than what their periods are doing anyway. So so it's not always necessary to absolutely know if they're definitively menopausal or not when it comes to managing symptoms.
Yeah, that's right. And for this lady, you will never know when she exactly became menopausal because you don't have that information. You will know that you could use symptoms or you could use bloods to know that she was postmenopausal, but you'll never be able to pin exactly when that happened. That's fine. That's fine. We're just thinking about symptoms. Okay, so let's I'll just so I can see where the questions are coming up, Kelly, so you can just interrupt me if you like. So we'll just look at menstrual changes, which of course if you've had a hysterectomy is not helpful at all. But if you go back to that slide we had on the straw criteria where they divide perimenopause into the early perimenopausal transition and the late perimenopausal transition, there is a difference in the symptoms people have. And so in the early perimenopausal transition, you've got your periods varying about plus or minus 7 days. That's when they become that heavy and clotty because you're not getting the you're getting the lining of the endometrium just building up and not stabilizing. Then in what we call the late perimenopausal transition, your periods are now skipping a month. So you might have 60 days between a cycle, you might have 3 months, you might have 6 months. Then they might be regular for, come back for a bit. It's sort of, but anyway, they start to skip cycles. At that point, they can be light or heavy. So that's the menstrual changes that we look at. Then we're going to go through other symptoms. So I find that if you listen carefully to what women are saying, you can actually differentiate between the early perimenopause, late perimenopause, and postmenopause. And I mean, you've got periods to guide you, but if you didn't have periods to guide you, you'd also be able to tell. So in the early perimenopause, you've got high estrogen and you've got your lower progesterone or low progesterone. So you get your menorrhagia. Often these women complain of breast pain, and that's from the unopposed estrogen, so the estrogen that was cycling quite high. They start to get mood and sleep disturbance. Hot flushes may be there, may not be there, mild. Complain of joint aches and pains, and it's commonly of ankle pains. So I always giggle when they say ankle pains, and they don't find that very funny, but they often complain of ankle pains.
And foot pain. A lot of them talk about foot pain.
Yeah, foot and some wrists. So it must be the smaller joints. Yeah. Migraines might change in their pattern, often an increase in migraines from the unopposed estrogen or the wildly sort of fluctuating estrogen. Can also get some exacerbation of autoimmune disease in the perimenopause time. Then in the late perimenopausal transition or later perimenopause, you've got lower estrogen and no progesterone. So now you're skipping periods, which could be heavy or light. Hot flushes are kicking in a bit more. You're getting night sweats, a lot of sleep disturbance. Complain about weight gain, especially around the tummy. Mood disturbance is worse. Anxiety, low mood, irritability, aggressive, some women describe themselves as. Body aches and pains, and because the estrogen is now dropping, you're getting vaginal dryness and dyspareunia. And urinary frequency can start, often it's a bit later. And loss of libido I put in there. I mean, loss of libido is something that sort of goes right through the perimenopause, early, late, and postmenopause time. And it's quite, it's complicated, that one.
It's absolutely normal at midlife, isn't it?
Yeah, it's everybody complain. They complain about hot flushes, not sleeping, mood changes, weight gain, and loss of libido. That's
absolutely.
Yeah. Okay, and then you've got your postmenopausal woman who's now got very low estrogen, no progesterone. So they're amenorrheic. They have hot flushes and night sweats, not all of them, but 70% of them. Sleep disturbance, mood changes, abdominal weight gain. Well, actually, yes, apart from the amenorrhea, I suppose it's similar to the late perimenopause, which is understandable. So that's the way I have come to think about it. Early perimenopause, late perimenopause, postmenopause, and all treated a tiny bit differently. And all symptoms are treatable. I think my last one is just to exclude other causes. So I always make sure when they're saying they can't sleep, low mood, irritable, very tired, aches and pains, just make sure that their basic parameters are correct, so that they're not iron deficient, they're not hypothyroid. Sometimes they say they're very tired, so sometimes you have to measure their autoantibodies. Lipid profiles worth doing, put in the liver functions, UECs. So that's more really to exclude other causes of the symptoms that they might be expressing. And I have never actually ordered in the menopause setting any bloods for anything fancy like pheochromocytoma or carcinoid. But I think it's something, those cause hot flushes. So it's something that perhaps if things are not adding up, or, someone's been postmenopausal for a long time and now suddenly they're getting hot flushes, perhaps we should think about. That was the diagnosis, definition, hormonal changes and diagnosis. So I think Kelly's going to speak next about
Well, I was hoping that Katie was going to speak next, actually, but it doesn't look like she's coming to the party, so I'm going to have to speak to her slides a little bit. But please, Lynda, do feel free to chip in any comments and things in case I'm missing something along the way here. So we're just going to go through a few main principles of MHT, menopausal hormone therapy, of course, which is the new common terminology for HRT, or which used to be hormonal replacement therapy. So it has to be said that when it comes to vasomotor symptoms, which is the hot flushes and night sweats, definitely estrogen therapy is the most effective treatment for vasomotor symptoms, hands down. It's like 95% effective at the treatment of hot flushes and night sweats. And it's also very effective at treating a wide range of other estrogenic symptoms in menopausal women and perimenopausal women. So another important thing to remember, and this should guide our approach to seeing these women in general practice, is that if there aren't any contraindications, it's actually really, really safe for women, particularly those younger women who are perimenopausal, early menopause, or at least, at least less than 10 years postmenopausal. It's very, very safe and often can be very effective and life-changing for some of them. So also, if there's no contraindications, they can take the MHT for as long as they need it. So basically, if you stick to the principle that they've started it at a young age and they're used it relatively continuously without long breaks, they can actually continue to safely use it for as long as they need it. So if they keep trying to come off it, their flushes come back, they can just restart it again fairly quickly, but maybe at a lower dose if they've been on it for a while, to see if that's effective. So the advice we know from all the compiled evidence with the International Menopause Society is that it is considered safe when it's initiated in younger women, definitely under the age of 60, and with whom there's no contraindications. So the safest things, oh, hang on, have I jumped a slide here or not? No, that's good. Transdermal estrogen is the safest. We know that if you take oral estrogens, it can slightly increase your risk of having unwanted blood clots. That's particularly so for the combined pill, which is much higher dose than MHT. But if people use transdermal estrogens, it doesn't increase their risk of getting unwanted blood clots. So the first principle is that if they're going to be using estrogen, the safest way to use it is transdermal through a patch or a gel. So it's a particularly good choice. I mean, it's a good choice for all women unless there's a reason why they don't want the transdermals, but it's particularly good for those who are BMI over 30 or smokers, or they're getting a bit older, or they have a history of migraines with aura or DVTs. So any of those people that you would not want to be giving the pill to, it's probably a good reason for them also to be on transdermal HRT or MHT. Thinking about topical vaginal estrogen, because not every woman needs systemic estrogen, it's very, very safe to use vaginal estrogens. And in fact, there's often thought given to that in women with dreadful genitourinary symptoms who've even had breast cancer, because it's very, very little or no absorption into the bloodstream. So it's very localized application of estrogen, which is very, very effective at treating vaginal atrophy and ureteric symptoms as well. And so you can continue to actually give that also with systemic MHT. So if a woman is going on estrogen therapy, but she's also got really, really bad vaginal atrophy as one of her main symptoms, I would be starting the two concurrently and actually continuing the vaginal estrogens as well for as long as it's needed. Okay, these are the lists of contraindications according to the best compiled evidence from the international sources and the Australasian Menopause Society as well. So really the only absolute contraindications for MHT are if they've had some kind of hormone-sensitive cancer like breast or endometrial cancer, or they have undiagnosed vaginal bleeding. So that is, some kind of change in their periods or, heavier periods that hasn't been investigated with some sort of abnormality ruled out. There's a lot of relative contraindications, as you can see there, but if they've got established cardiovascular disease, obviously you do need to tread carefully and lean towards the transdermal estrogen every time rather than the oral estrogen. And you notice here as well that SLE and some autoimmune conditions may be a contraindication, depending on how active the disease is and whether it flares when you give estrogen. Because estrogen is an immune booster. It actually helps to prime the immune system, which is one of the reasons why it might cause flare-ups in some autoimmune diseases. Interestingly, women die at lower rates from COVID if they're on MHT compared to women who aren't as well. That's how powerful the effect of it is. Now, this is Katie's slide about putting the breast cancer risk into perspective. When it comes to breast cancer risk, it's only certain types of MHT that have ever been linked to an increase in breast cancer risk. Some of the older synthetic progestins that were used in combined MHT can slightly increase breast cancer risk after 5 years of use. And that increase is in the order of what they would get from drinking 2 glasses of wine per day. And when we put that in perspective against lifestyle risk factors, if they are 20 kilos overweight, that doubles their risk of breast cancer. So things like being overweight, drinking alcohol, being sedentary, smoking, those are much, much more powerful, risk promoters than any HRT. So it's also important to notice that, depending on the type that we choose, there may be no known increase in breast cancer risk at all. So we lean towards using micronized progesterone or Mirena as the stabilizer of the endometrium in women who are using estrogen therapy, because neither of those have been shown to increase breast cancer risk. And this is just an example of an infographic that can be used to help explain to your patients. This one comes, I think, from the British Menopause Society, because that's where Katie came from. But it's quite a nice way of demonstrating that actually women who are on estrogen-only MHT actually have a lower risk of breast cancer than women who aren't on anything. So, it's interesting to put into perspective, the women who are overweight or obese, doubling of their risk of breast cancer. So just having little tools like that can really be helpful for explaining it to your patients. And the other thing to remember is that it's one thing to sort of say, okay, well, this woman has got some symptoms. Will I or won't I treat her with estrogen therapy? Not so sure. Maybe I shouldn't do it. But you may be actually denying her some quite good long-term health benefits in not letting her try it. So, we don't primarily prescribe MHT just for cardiovascular protection, but it's a nice side bonus. We know that women who are on MHT actually do get cardio protection and protection for their bones for the duration of time that they're on it. So, if the woman is getting great benefit from being on the MHT, if it's really helping manage her symptoms, she's started it appropriately, she's a low risk candidate, for the duration of time that she's on it, she's getting that cardio and bone protection, and that moves with her as she ages. So, forever and ever, she's going to have that 5 or 10 or however long she was on MHT. She's going to be carrying that benefit with her as she ages in terms of, where her cardiovascular risk is at. Okay, so when it comes to MHT prescribing, the things to think about is, number one, that every woman is different. They're all going to react differently to the different hormonal products, and they're all going to have different ranges of side effects. So there's no one-size-fits-all approach here at all. We always go from an evidence base in this space, and always, explain to women what we know of the population risk and benefits here. But until we try it on an individual woman, we really can't speak to the benefits she's going to get. So often it literally is a trial and error. We try something, we sit with it for a while, we see what benefits or side effects or whatever she's getting, and then we reassess as we go. So I've put together a bit of a simple guide to MHT prescribing, and you'll all actually be receiving a copy of this afterwards as well as a downloadable PDF. So you don't have to madly scribble or worry about missing anything. You can also go back and watch the video again later. But the simple basic facts that when it comes to approaching MHT prescribing is that if they haven't got a uterus, you can give them estrogen alone. If they do have a uterus, you need to give them estrogen plus something that thins and stabilizes and protects the lining of the uterus from being thickened up by the estrogen. And usually that's a progestogen, which is either progesterone or a synthetic version of progesterone that does the same job. So those are the two things. They're either using estrogen alone if they don't have a uterus, or estrogen plus a progestogen if they do. And that's called combined MHT. As we've heard, the transdermal estrogen is the safest. And as far as the progestogens go, the ones that definitely so far have not been shown to increase breast cancer risk is the micronized progesterone, most commonly marketed in Australia as Prometrium, and the Mirena also, which is a really lovely, convenient way of delivering progestin directly to the lining of the uterus, and also giving them low circulation of the hormonal product and giving them a contraceptive benefit and making their periods lighter. So there's loads of reasons why Mirena might be indicated in a perimenopausal woman. So if we give it around the start of menopause or around the normal menopausal age, I would normally start with a medium dose estrogen, as your start point, which is about the equivalent of a 50 microgram patch, or which is 2 pumps of the estrogel or 1 sachet of the Sandrina. Those are our main transdermal products. For a younger woman or one that's gone through a sudden, like a surgical menopause, they may have more symptoms and they may be more severe and go on for longer. And so they may also need higher doses of estrogen. So again, starting something, watch the effect, monitor it over time, and then maybe increase or adjust as needed. The medium dose MHT is well balanced either by a Mirena, or if the woman's not having any periods, you can give her 1 capsule daily of the Prometrium at bedtime because it helps them go to sleep. It has a nice calmative effect and helps them sleep a bit better. Or if they're still cycling, you use 2 capsules of Prometrium nightly for the second 2 weeks of their cycle. And that's what we call cyclical MHT. And then every once in a while, you might want to, say on an annual basis, advise them to do a trial off their MHT to see if they still need it for their symptoms. And if they do, you can either restart it or even consider restarting at a lower dose if they've been on that for a while, just to see if they can get away with a lower dose now. So again, going back to the Mirena, if they've got heavy periods, menorrhagia, or are needing contraception, then I would be leaning towards suggesting a Mirena for them. Whereas if they are, have a lot of anxiety or a lot of difficulty sleeping and then need a nice calmative benefit, I'd be leaning towards the progesterone as the progestogen for them. The progesterone itself and a lot of the progestins can give side effects, hormonal side effects like breast tenderness, nausea, bloating, moodiness, reflux, those kinds of things. If the woman's complaining of progestin-related side effects, the good thing about the Prometrium is that we can actually use a lower dose of it vaginally because it's so beautifully absorbed vaginally. It can actually be used, say, instead of using it every night orally, she could use it every second night vaginally. Now, that's an off-label use, but very widely done by specialists in the menopause field, and it really helps a lot because it helps to reduce systemic side effects that they've been getting from the progesterone. And also it's cheaper because, obviously, private scripts can be expensive over time as well. There is a combined estrogen patch with a progestin added that you may know of, the Astalis, and that can be a convenient starting point, particularly if you're worried your patient's going to have difficulty managing to do 2 separate things. If she's got to keep track of her cycle to remember when it's day 15 to start her progesterone, and then she's got to remember to change her patch twice a week or put a gel on every day. Sometimes just as an initial thing to get them used to it, starting with a combined patch is nice and easy, and that's great. As long as she understands that as a long-term product, that there may be an increase in breast cancer risk after long-term use, and that maybe after a while it's better to be transitioning to one of the other progestogens that hasn't been shown to do that. If she prefers tablets, which a lot of women do, they like the convenience of that. As long as there's none of those increased risks of unwanted blood clots, and if she's fairly young, particularly, say, well under 60, sure, if she's low risk anyway, it might be a nice convenient way of delivering it for her, at least in the short term. And we know that dydrogesterone, which is the progestin in Famostin, is one that's probably going to be safer overall with respect to breast cancer risk than some of the older products like norethisterone and medroxyprogesterone acetate as well, which is like the Provera and Primalute type products. There are, for people who want to have a look at, how much of the progestogen they should be using to balance which dose of estrogen, the AMS has produced this beautiful guide, equivalent MHT dosing guide that you can get. And the link to that's also going to be in the PDF that's going to be delivered to your email. So don't worry about scribbling that down now, but you'll be able to look at it later. We find at WellFemme it's also very good practice to be doing a symptom score, because if you're going to be doing trial and error to try and work out what's best for an individual patient, it's lovely to be able to monitor the response and quantify it in some way. So that's what we do, is we use the Australasian Menopause Society's symptom score chart, which is the one you see here on the screen at the moment. And so we'll start it at the beginning before she's started on a treatment, and then after 3 months of treatment we'll get them to come back and recheck the symptom score, and then it becomes very clear which things are being helped, which things aren't, if any things are worse, and that helps us to adjust what we're doing accordingly. The AMS also has a lovely range of information sheets. It's also good practice, I feel, to give them something to go away with to read. And so if you start them on combined MHT, you can give them a handout from the Australasian Menopause Society, which just goes back over all of the safety aspects of it that they might forget after they've left your room. And you can show them the website and say, have a look at all of these great different topics that are on there. Okay, so I've put together a little algorithm here for you, which I won't go through in great detail now, but it's basically, if somebody's got hormonal symptoms, we need to exclude the other potential causes of their symptoms. But if the symptoms might be hormonal, if they're at the sort of age that you would expect to see these sort of symptoms happening, then think about whether or not hormonal treatment might be appropriate. Is she cycling? Yes. If she's having mood symptoms, migraines, but still getting somewhat regular periods, then she's in that early perimenopausal phase that Linda described earlier, which means that they might actually be still quite well estrogenized, still ovulating fairly regularly, but that the progesterone level might be starting to get low, and that might be causing deepening of the premenstrual type symptoms and migraines. So in that situation, you might want to talk to the woman about some alternatives, like, well, for example, we could start you on combined estrogen and progesterone at this point, or some combined MHT to see if that helps to level out your symptoms. But if in fact she's quite low in progesterone, you might get, she might find that there's quite good benefits just from progesterone alone. Now, I have to stress that this isn't medically indicated. It's not one of the medical indications for progesterone. It's more like using it in the realm of a supplement. But it's something that might be worth trying. So saying to her, well, we could do this combined therapy, or we could try bringing the things in one at a time, and that way we know what it is that's being effective for you. So you could start her on some progesterone for a while, monitor how she's feeling. If that's not doing anything or she feels worse, then you might want to go down the path of adding some estrogen to that. But basically, if she's low risk, there's not a lot of harm in trying. If she really wants to try something, and she's aware of the potential side effects and things, and she's low risk, sure, it might be worth just trying it to see if it makes her feel better. So yeah, we can go down this pathway here. If she's got a fair bit of flushes and sweats, then she might be getting more into the sort of late perimenopause with low or rapid changes in her estrogen and actually need a bit of estrogen as well. You can, over here, is she having any periods? If she's not having cyclical symptoms, is she having periods or not? Does she have a uterus or not? That will guide what you're going to try next. And then also don't forget about the issue of contraception down here. For women who have got quite bad PMS, PMDD, menorrhagia, you might want to be thinking about actually suppressing ovulations, and there's a different range of products that will do that. But if she doesn't actually have those sort of problems, but she does need contraception, then Mirena is a really good option as well. So Mirena, it has to be said, does not suppress ovulation. So if you're thinking that it's going to level out her PMS symptoms, it may well not. It might help her menorrhagia, but it's not going to help with her cyclical symptoms if it's not going to stop her ovulating. And I'll just make a quick mention of a new product that you may have heard of down here called Slinda. Now, Slinda is drospirenone, which is the same progestin that's in the Angelique combined pill, combined MHT. And the difference with Slinda is that it's the first progesterone-only pill that actually stops ovulations, which is why it's so forgiving if they miss a pill or they're a bit late taking one of their pills. The good news about that is that it gives us an option for treating those women who have got PMS or PMDD and we want to suppress their ovulations, but maybe they have a contraindication to using oral estrogens like the pill to do that. So Slinda might be an option for some of those ladies. Right. So anyway, what I wanted to get across, I guess, more than anything was that there is a really unfortunate perception that MHT is a dangerous thing to use, and GPs will back away from trying it with their patients in favour of using things like antidepressants or even anti-epileptics, which have a much bigger range of potential unwanted side effects. So my take-home message here is that it's actually quite low risk if we're looking at the women who are younger and have no contraindications, and you can't do a lot of harm from her trying these things. If she doesn't like it, she can stop anytime she likes. And, there's very few, very low risk of any sort of irreversibly catastrophic side effects happening. So if there's a chance that she might feel better and she's really keen to try, offer her something. She can try these things quite safely, and if it's not working, then you can change tack. Now, we do have some case studies here. How are we doing for time though, Michelle?
Yeah, we're going well for time, Kelly. So we're all good. Can I just ask one question, which is relevant to what you were just talking about? When women trial going off MHT, do you suggest gradually reducing or stopping suddenly to see the effect?
Yeah, that's a really good question, because a lot of women feel like that if they're on MHT, they're just putting off the inevitable, that when they come off it, their flushes will come back. And look, that may be the case, because I guess if you think about it, like as though their body is in withdrawal from estrogen because their estrogen has declined quite rapidly, their body has to get used to this lower level of estrogen. So you're supplementing it in the meantime to soften the symptoms. So, what I do with my patients is I just ask them to, in winter, maybe on an annual or every second year, in winter time, to just stop using the MHT and just sit back and see what happens. If they've been on the same treatment for quite a long time and their symptoms come back, then I usually say to them, why not go back on just half a patch, maybe cut the patch in half, or go back on a lower dose just to see if you really need the same dose anymore. But yeah, I usually just get them to stop it. What do you do, Linda?
Yes, similar. So women often ask, well, when do you stop and how do you stop? And I think it happens a few ways. Women run out of their script and they find that they're fine, or they decide themselves that they're going to decrease their dose, and they're not silly. They'll work it out. They'll do one pump instead of two, or, you know, one half a patch instead of one, and they get down to small amounts of patches, you know, they wear themselves down. I'm quite sort of medical model. So at 60, I do say that the International Menopause Society says that the benefits of MHT probably outweigh the risks until age 60, and then we don't know. So I'll provide a bit of encouragement to stop, you know, to maybe decrease, stop, have a try at 60. And then we just have to see what happens. Some women are fine, some aren't. Some, you know, simply refuse to come off their MHT, you know, you know, life, you know, whatever. So you just have to play it by ear. I mean, it's a journey, really. Yeah.
Yeah, I've heard some of the specialists talking about how they've still got ladies in their 80s who are using like a minuscule strip of a 25 microgram estrogen patch or something, because they still get flushes if they don't keep going on it.
Yeah.
And
so
it's probably safe.
I don't know, but they want to do it. So
yeah.
So the long and the short is I would wean them down. And mostly they're okay. Sometimes they go back on the MHT for a bit, and then they have another trial at stopping because at some level they want to stop. And then the next time it's, you know, not such a quick, you know, they don't get as many symptoms. So I don't know.
Yeah. So I'm just noticing somebody's talking about bioidenticals in the chat box, and just quickly while I'm thinking of it, remember the difference between bioidenticals and body identical here, because the phrases get a bit mixed up. But in general terminology, body identical is what we're talking about with the TGA approved products that we're using in the MHT space, like the estradiol patches and gels, and also like the prometrium, which is micronized progesterone. These are the molecules that your body naturally produces itself during the reproductive cycle. Bioidenticals tends to refer to stuff that's been compounded and is not those molecules, but tends to be a precursor molecule that your body breaks down to the same thing anyway. So what women don't understand is that the end result is pretty much the same, but that they're using a product that's not been TGA approved and is not regulated, and we can't be sure of the consistency of the dose and the contents of it, or the long-term safety of it. So yeah, there's, you know, women are often very happy to hear that they have a TGA approved alternative to their bioidentical troches or something that they've been using for ages.
Bioidentical hormones are also very expensive. So
yes,
sometimes cost is the reason why people will come and visit WellFem. That's what I found, Kelly.
Yeah, you're absolutely right.
The menopause space, they don't, you know, we don't like bioidentical hormones, or not, you know, we don't advocate for them.
Yeah, I've got women who are coming from some, you know, they've gotten a free over the phone consultation and then been signed up for $250 a month of, you know, compounded stuff to get sent out to them in the mail every day, or every month, I mean. So, you know, it gets very, very expensive, and they're very vulnerable, these patients, to that sort of thing if we don't really listen to them and offer them something. Okay, case studies. Lynda, why don't you go with Steph?
Oh, yeah, okay. So Steph is 38, and she's got no past history. She's got 2 children, age 8 and 5, and she's got a Mirena for contraception, so she's amenorrheic with that. And she's seen us in the last few years feeling tired. She had body aches and pains. You know, she had 2 young kids. Autoimmune screen was negative. She came another time, low mood, irritable, you know, hasn't had a history of any mood changes. Iron studies, thyroid function studies, sugar, all normal. And like, she's like a lot of our patients, you know, in her 30s, very busy, working, had to be, you know, was reassured she had a lot on, you know, advised the usual sort of good health stuff, exercise, makes you less tired, have a healthy diet. If your mood's low, you could consider a psychologist, you could consider antidepressants. That wasn't discussed though. And then she represents with hot flushes. So now, you know, your little radar's on. So hot flushes in a 38-year-old woman. So we repeated her bloods, to wondering about, again, hypothyroidism, you know, iron deficiency, but added FSH, LH, estradiol and progesterone. And her FSH came back high, and her estradiol came back low. So what do we do? So Kelly, should I just go on? I've done another slide, or do you want to discuss?
I think so. I mean, we could. I'm happy if anyone in the audience wants to please, pop in your comments about, the particular cases and how you would approach it. We'd love to hear from you. This is interesting, though, in the sense that it's one of the few cases where we do actually do bloods to diagnose, right, Linda? Because not the typical menopausal age, and we need to rule out those other causes.
No, that's right. Yeah. So she's got premature ovarian insufficiency. So, and she needs a lot of reassurance, this lady. So we'll go to our next slide. Hopefully that'll work. Yep. So actually in this case, I would repeat the bloods, Kelly. She's got the symptoms. She's got the high FSH. We know she's perimenopausal or maybe even postmenopausal. But we can get a clearer diagnosis if we repeat the bloods. So we repeat the bloods in 6 to 8 weeks. And again, her FSH is high. So now we can say with some confidence that she's got a POI, so premature ovarian insufficiency. That's a very devastating diagnosis to get. So she needs a lot of counselling and support. She's got 2 children, which is great. But we have to manage her now. So she has to have estrogen to the usual age of menopause, which is 51, 52. Then she can decide. She also needs contraception because some of these women just spontaneously ovulate. She may, if she doesn't mind falling pregnant, that's fine. But if she doesn't want to fall pregnant, or that will be too devastating for her, then she needs contraception. So she's got her Mirena, which is good for her progesterone part of her MHT, and also contraception for 5 years. So she was put on a patch. She came from Sydney, actually, this girl. And she initially started on 100. She was told by the gynecologist she could go up to 125. She said to me when I got her that she didn't feel so good. She felt tired, and she knew that more estrogen would make her feel better. So I sort of thought 125 is quite a high dose. We measured her estrogen, and it was actually sitting at 80, so that's quite low. So she took herself up to 150, and we remeasured it, and it was about 400, I think, which is pretty normal. And we haven't measured it since. You don't need to measure it. She feels fine. Other things about her is you've got to manage her cardiac risk factors and her bone density. So other considerations, if we'd acquired this lady in her early menopause, other considerations would be, with this new way of thinking of estrogen and progesterone both perhaps being important, would you add progesterone despite having a Mirena? Would you take out the Mirena, put on continuous MHT? Or, she could go on Zoli. Sorry, I spelled Zoli incorrectly because it's got estradiol, and I spelled that incorrectly too, as its estrogen component. So what do you think, Kelly?
No, I think it's a really good example of a case because, we know that there's a strong association with premature ovarian insufficiency and premature heart disease and osteoporosis. So it illustrates beautifully the need that you have to supplement their estrogen up to the normal menopausal age if you find somebody like this. So super important. I think it's great that she's got the Mirena. I mean, hers is a situation where she's come with flushes in the first instance. So she's kind of already gone through that early perimenopause and things, I think, even before that, and sort of gone straight on. So I wouldn't worry about necessarily doing progesterone, by itself in this situation, unless she wasn't feeling awesome or she had sleep problems or something like that on the estrogen alone, like estrogen with Mirena.
When I said progesterone, I meant to her estrogen. So
yes,
clearly,
yes, that's right. But as well as, because we often do try that, like even in ladies who have a Mirena who come in early perimenopause, I sometimes will do that stepwise thing where, we have a talk about it. And if they think they'd like to try the progesterone first, then we try that. And then they decide whether or not they need to add estrogen as well. So, no, I think that's good.
I mean, that progesterone only does seem to relieve a lot of their joint aches and pains. So seems to work quite well in that
And
regard.
it's calmative. They love that kind of calmative sleep effect that they get when they take it orally as well. They don't get that with the vaginal use.
Yeah.
So I'm going to go into Katie's slide now.
Yep.
She had a case study here who was a lady in her late 40s attending for a menopause consult. She had a menopause symptom score of 32, and she listed her most severe symptoms as reduced libido and sleep disturbance, which is fairly typical. She also had moderate sweats and flushes, headaches, depression, anxiety, mood changes, and urinary frequency. So her cycles are a bit erratic, going from 23 to 35 days and heavier than they used to be. So kind of a fairly typical, perimenopausal lady, probably mid to late perimenopause, I would say there. And the things that Katie wanted to bring out for this particular case was the issues of contraception, because I think in that first slide it said she wasn't using any contraception. So this is the thing, a lot of ladies in their late 40s, they'll come in with perimenopausal symptoms, and you say, what contraception are you on? And they go, oh, I'm not using any. I'm not going to get pregnant at my age. They're really quite sure they're not. But I'm sure every practice has its stories of ladies coming in thinking they're menopausal and finding out they're pregnant because their period stopped. So you do need to make sure that they're understanding they need contraception. The rules around that in accordance with the World Health Organization, I think it was, is that if they're under the age of 50, they should be using some form of contraception for 2 years after their last period, and if they're over the age of 50, for 1 year after their last period. In this lady's case, if we were going to use MHT, we would probably use it cyclically because she's still having a somewhat regular cycle, but it does get a bit tricky sometimes if their bleeding becomes very erratic for them to work out where they're at in their cycle and how to apply the progestin exactly in the second half of the cycle, which is called the luteal phase. So it can be a bit tricky, and sometimes we have to be a bit creative in trying to work out how to deal with their erratic bleeding. But marine is a great way to deal with that, particularly in a lady like this with heavy periods. And also the preventive healthcare opportunity that this time of life represents. For example, she could have a 45 to 49-year-old health check potentially to have a really good once over. And a cardiovascular risk assessment. You get a really good history, make sure that she's normal weight, which this lady is, and that her exercise activities and diet and everything are good, because going into menopause, her physiology will change quite a lot because of the low estrogen, and she needs to understand what that could mean for her after menopause. And so getting everything lined up health-wise ahead of time is great. What did you have any other comments on that particular presentation, Lynda, that you think haven't been brought out?
So I think this is the sort of lady that does really, really well on MHT. So if she was open to that, when I see patients, I go through lots of options, and the last one is MHT. But if she was open to MHT, she would do really well on MHT and cyclical. And I'm just starting them all on prometrium now, like as in estrogen and prometrium together.
Yes.
And sometimes, of course, we can separate it out if you could in this lady, separate it out, but either prometrium only or prometrium and estrogen together. If the heavy periods bother her and they don't settle down a bit on the cyclical prometrium, then obviously a Mirena and estrogen would be a good thing. Yeah. So she's very, very typical. I'd say sort of middle, somewhere just between early perimenopause transition and late. She's sort of just there.
Yeah. I'm going to, Michelle, we're at 8 o'clock already. I'm wondering if we should maybe either sacrifice some of these case studies or scoot through them super fast so that we can get to some questions. What do you think?
Yeah, absolutely. I've just got 2 questions which are relating to the case study we were just talking about. What are your thoughts on testosterone for low libido?
Yeah, that's a great question. Because libido, like they'll all say they have a low libido, and it's absolutely normal. But you've got to ascertain what they mean by low libido, I think, in the first instance. Do they mean that they're just not feeling horny all the time? Or do they mean that when they do engage in intimate activities with their partner that they can't become aroused and orgasm? So I think they're very different problems, because there's a lot of psychosocial stuff that gets in the way with people wanting to initiate sexual activity. But if she can actually enjoy it and become aroused and orgasm when she does engage, then she's probably quite normal. And it's just a matter of actually managing how they make sure that they create those opportunities as a couple for closeness and intimacy when they're both not distracted or have kids around or, completely exhausted. So yes, in people who have a response disorder, who aren't being sexually responsive very well, if they're already established on MHT, there is some evidence that for postmenopausal women who are established on MHT, that sometimes the addition of testosterone can actually help with their sexual responsiveness. And we also find that it can help a little bit with their cognitive functioning, muscle recovery, and mood as well. Would you agree, Lynda?
I haven't really been doing this long enough to sort of actually have any good opinion about it. So I find putting people on MHT improves things enormously. So I more go for the diet, exercise, the decision-driven sex. So the book by Rosie King about where does my libido go?
I love that one.
Yeah, it's great. Yeah. So giving yourself space, giving yourself time, sort of more focusing on that, topping up your estrogen and progesterone, and sort of seeing what you've got. And so far, that has been fine. So far, people have improved hugely. I did read about a paper about testosterone and sexual function, and it did say, and I can't quote it because I'm not in the sort of specialist mode, but that on topical testosterone, these trials showed that they got 2 extra satisfying sexual events per year. And I thought, for all the measuring of hormones that, you have to measure every 3 weeks. And also the other thing is testosterone was not really available for women in Australia until December last year. So people were getting testosterone, but it was off-label. So I suppose I don't have I'm waiting. I will prescribe it when the time comes and it's needed, but I really haven't found the need yet.
Yeah, I find that the reality is that there's probably very few women that I really think are going to benefit from it. So, even though they come because they've heard that testosterone will help with their sexual, with their libido, when we talk it through and, try all the other interventions first, I think there's very few of them really that the testosterone helps their sexual function that much.
Yeah.
So someone's also mentioned Livial in the chat box. Livial is not it's not estrogen and progestin like your typical MHT. It's actually a selective estrogen receptor modulator. So it does the estrogenic effect in your bones and in your brain and the places you want it without stimulating the uterus to overthicken or anything like that. It's quite a good choice for women who just need a low dose MHT solution. It is oral, so in the over 60s, it has been shown to slightly increase their risk of unwanted blood clots, so use with caution in the over 60s for sure. And it can only be used in women who are no longer having periods, so definitely the postmenopausal women. But some of them do find that they get a little bit of a testosteronizing effect from that. But you're talking about your women who are more suitable candidates for the lower dose MHT and already postmenopausal there. So I might just abandon any more case studies if you think we've got lots of questions to get through there. Michelle, what do you think?
Yeah, absolutely. Sure can.
Before we wrap up, though, I will just say a word about WellFem. We've been going now since 2018 doing telehealth menopause services for women, and the demand is really growing and growing and growing. And of course, you know, telehealth is now much more widely accepted because of COVID and people using it commonly. But you know, we're here to support GPs because we're, you know, we aren't the ladies' regular GPs. We all are GPs and we have our own general practice patients, but we're not going to be the GPs for these women in WellFem. They are coming to us just for some, you know, more specialised advice, particularly about their menopausal issues. So, you know, it's really, really super important to us that we can keep that continuity of care with the patient's regular GP and make sure everyone's on the same page about, you know, what the aims of treatment are and what her risks are and all of that sort of stuff. So we do have some resources for GPs on the website. You can actually click on and do a referral, and I'll show you a picture of the website in a moment, where you can click on to refer one of your more complex patients, for example. But we're going to, you know, make sure that we've got some resources up there. We're going to provide these sort of educational opportunities for GPs, and the handout that's coming around to you will also be on our website soon as well. And as the next step, if any of you are particularly interested in taking the next step to becoming a bit more expert in prescribing MHT, then please, when you do get your email, click and register your interest for a future masterclass in MHT so we can bring you along to the next step of expertise in MHT prescribing. And there's also a spot on our WellFem if any of you are particularly great at treating menopause and really love it. We'd love to hear from you because we've got tons of patients who could really use your care, so please let us know. And this is a picture of our website here when it comes up in a moment. And if you click on the 4GPs bit, you can make a referral, find out a little bit about WellFem or becoming a WellFem doctor. So we would love to hear from you, and we welcome communication with patients' GPs so that they can give us feedback about what they're noticing as well, or if they have any concerns. So on to some questions, I think.
Yeah, fantastic, Kelly. And I have also just dropped the link in to sign up to that masterclass in the chat right now. So that is there and available if anybody wants to jump in and just pop their name on that list. So thoughts on antidepressants for the low mood, anxiety and other treatments first?
Well, if it's part of their perimenopausal or menopausal symptoms and they are wishing to take MHT, you may as well start that first and see what happens, because often you find that the anxiety decreases, their mood improves, you know, the irritability goes away. If you, so in someone in the setting of perimenopause, I would fix their hormones first. And then look at what you've got, and then you may or may not need to use antidepressants after that. If they're depressed, and you do get the sense, you know, when you talk to someone, whether they're truly depressed or they just sort of menopausally kind of, you know, sick of the world, there is a difference. So if they're truly depressed, obviously they need antidepressants, but if they're perimenopausal and their mood's dropped, then you know, they need an approach to that. And it may not necessarily be an MHT. It might be exercise, diet, you know, it might be SSRIs to treat their hot flushes. That's what I'd do. What would you do, Kelly?
Yeah, I think you do get a sense after a while of treating these ladies, there's patterns, right? It's a bit about pattern recognition. If you've got someone in front of you who very, very clearly had these cyclical mood problems starting, you know, only when they hit perimenopause, and they haven't really got a strong history of having any kind of mood disorders previously, I think I'd be leaning towards starting with MHT, because it sounds like it was triggered by hormonal issues, and that maybe if we stabilize the hormones, we stabilize the brain chemistry and they feel better. But, you know, if somebody's got a very big history of, you know, mental health issues, even premenopausally, then you might find that even if you're treating their hot flushes and everything else, that you might still need some antidepressants on top of that anyway. So again, this really individualized approach depending on the woman right in front of you.
And I think you just have to add that perimenopause is a very vulnerable time for women's mental health. So your mental health goes off with hormonal changes. So when you're an adolescent, postpartum after you've had a baby, and then perimenopause is your other danger time. So just to put
So
that
true. Yeah. Somebody there I noticed has asked about oxybutynin. I actually had that on one of my slides. I think it was I had a slide about a much older lady, so sort of over 60, who's been putting up with dreadful hot flushes for more than 10 years, and she's sort of on the cusp of being 10 years postmenopausal with a lot of genitourinary symptoms. And couldn't take MHT because she was too far post-menopause to take MHT. But oxybutynin is something that I use a little bit in that situation, particularly if she's got irritable bladder or overactive bladder. It's a great way of covering off a bunch of things. So I do find that sometimes using oxybutynin will help them to, their flushes and sweats will settle down a bit, and they get less of that irritable bladder type stuff to boot. So you've just got to manage that imbalance with the anticholinergic symptoms.
We've got an interesting comment here. As an English GP, I've noticed that poor knowledge of GPs, especially men, about MHT. Women are led to believe that it's not good for them. I feel like I'm the MHT warrior.
Good, we need warriors.
That's right.
I've got an observation
We
for
might need you in WellFem.
So Australia, I've watched over sort of 25 years, Australia sort of lags behind the UK in lots of things. So I remember the chickenpox vaccine, we didn't have it. It was terrible, no good. UK had it, and then, 5 years later we got it. There's been lots and lots of things, and MHT is one of them. So I think I'm afraid we're a colony. we're just catching up. So you're correct. It's people have got a very poor knowledge of MHT, but Kelly's trying really hard. So,
but I really believe actually that we're riding the front of the wave of something much bigger here, though, because this is getting internationally, the conversations around menopause and MHT are getting very much louder. There's a big push, for example, to talk more about menopause and its implications in the workplace for productivity and, the social aspects of it, the fact that women feel shame for having these symptoms in the workplace and worry about whether or not they're actually up to the job because their cognitive function is being clouded and things like that. So, there's a lot of education happening in workplaces and a lot of industries and policies being developed around it. And I think that, the evidence is very, very clear. We've known about MHT for, like 20 plus years, or certainly in the last 10 years in that reassessment of all of the data from the Women's Health Initiative. We've known for a long time that it was actually, quite safe and effective, really, except in, a few very strict circumstances. So, yeah, I think every one of us can be MHT warriors if we're actually, fully over the facts about it and the benefits that it could be giving to our women when we offset it to the very low risk.
Absolutely. Do you have any thoughts on perimenopausal psychosis?
Linda?
No, I don't. No, I mean, it's a vulnerable so I haven't actually seen that, but but it is a vulnerable time for women. So I suppose if they've got a predisposition to becoming psychotic, it might occur. But I've not actually heard about just straight menopause, I'm not sure. It's not something I've seen. Is it something you've seen, Kelly?
I've had some very, very severe PMDD ladies to the point where I've referred them to reproductive endocrinologists to have, something like Zoladex to put them into an artificial menopause because, they absolutely, they were just, getting so suicidally depressed every month. They absolutely had to have their ovulation suppressed, and then they were given, estrogen rescue after that, like just to get their estrogen. So it's definitely a thing, and as you say, those hormonal changes are a very powerful trigger in some people for serious mental illness. So I don't doubt it. Somebody asked, can we use estrogel and prometrium for perimenopause women who still have periods? The answer is absolutely yes. But if they're still having somewhat regular periods, you would just use the prometrium cyclically. So, you know, you'll use the estrogel. I would typically start with 2 pumps for a fairly young woman, and using 2 capsules of prometrium on days 15 to 26 of each cycle if they're somewhat regular. Would you agree, Linda?
Yeah, absolutely. No, totally. Yeah. I mean, that's the time. In my opinion, perimenopause is the time to start MHT. Really. I did see one flashing past, Michelle, about supplements in perimenopause or menopause. Have you got a list of the questions that have come up?
Yeah, you scroll up. Yeah.
There was a question, can you comment briefly on the alternative medicines used in menopause space? Yeah.
Because people often ask about that, and I always give them the option of, you know, especially where I work in Canberra, that's a very, very, you know, they like that option in Canberra. So there are plant estrogens, phytoestrogen supplements that you can buy. There are some foods that you can try and top up your estrogen with, but none of it works as well as MHT. So it's really for someone who is sort of doesn't want to take MHT for one reason or another. There is a type of magnesium glycinate that's better absorbed for hot flushes. And there is a book. Are we allowed to say the names of books?
Oh, yeah, I think so. It's one of our faves, isn't it?
Okay,
fact,
it is.
I might have it. Hang on, I might have it here.
No, I've got it here because I got up to fetch it. And so this book,
yeah, that's the one. Yeah.
Hormone Repair Manual by Lara Bryden. She's a naturopath, but it's based on a book written by her friend, a Canadian professor of gynecology, and I forget the woman's name. So medically, it's very correct. And then it goes into MHT. It also goes into a lot of the progesterone-only stuff, which is what someone else asked about. And it has quite a lot about supplements. So I couldn't manage all the supplements. It was too detailed and too much. But there is a hell of a lot of different supplements that are going around. But, I mean, I would just say the phytoestrogen ones, Kelly, like red clover. You're not into that much, but I just give it as an option. Yeah,
absolutely. And a lot of women are. That's the thing. You know, we can't discount that. I think we have to remember to ask the question, you know, what are you taking, you know, besides the stuff that I prescribe, you know, what supplements, what vitamins, because you really have to have a good sense of all of that stuff going on as well, and be open to it as long, you know, so that you know about it and can make sure that they're not coming to any harm.
Yeah. But that Lara Bryden book is very good, I thought.
Yeah. Somebody here has asked, what can help with night symptoms continue even with MHT? And I think, you know, well, number one, always be thinking, so if a woman's got dreadful hot flushes and she's of menopausal age and you're thinking, oh, it's definitely got to be her low estrogen, and you give her estrogen and she's not feeling any better, then I'm starting to get a bit suspicious that maybe there's some other cause for those hot flushes, because we know that estrogen therapy is like 95% effective at helping, you know, menopause and perimenopause related hot flushes. So, you know, number one, keep your radar up for the woman who's not getting better, who you assumed to be having menopausal flushes, and make sure that it's not something else. But if you absolutely have excluded other things, then there's that a full range of non-hormonal options. And there is a very good information handout from the Australasian Menopause Society on their information sheets page, which I have linked to in the PDF that's going out to everyone. And so the one that's called non-hormonal treatment for menopausal symptoms, it lists things like the different types of SSRIs and SNRIs that can be helpful. Also, things like gabapentin and clonidine can be useful, and oxybutynin, as I mentioned as well. So there are other non-hormonal treatments which have been shown to be effective for hot flushes and vasomotor symptoms. Yeah.
So we've got a question here. There's a young woman with migraines plus aura. Can they also safely have estrogen and prometrium for perimenopausal symptoms?
Yes.
I mean, it's my understanding. Yeah, that's right. So migraine's not a contraindication to having HRT.
Yeah.
I
The
mean, it's a
basic
contraindication
principle.
to it, but it's not.
Yeah, the basic principle, as mentioned earlier, is use it transdermally. You know, like for anybody that you worry about their risk of unwanted blood clots, always lean towards the transdermal estrogen. But you know, remembering that the estrogen dose, even in oral MHT, is much lower than it is in the pill. So you know, you don't have quite the same level of risk of unwanted blood clots from oral estrogens. But I would still, you know, wherever possible, use transdermals, much safer.
Excellent.
Sometimes they say that their migraines get worse with MHT, and sometimes they get better. Like sometimes they go away. It's very unpredictable. So you have to just take that into account too.
Can you explain regarding patches versus the gel application? I'm confused. Do I have to use the gel rather than the patch in the view to reduce breast cancer occurrence?
Yeah, it's good. Yeah, so that related to what Kelly alluded to in the patch. When you've got the progesterone, you haven't got the body identical progesterone. So I think you've got levonorgestrel in a patch, haven't you? I don't use it.
No, it's norethistron, I think. I can't quite
Norethistron. Yeah, it is. It's norethistron. Yeah. So in the gel, you've got estrogel, ethinyl estradiol, and in the patch, your estrogen is estradiol, not ethinyl. It's estradiol. In the patch, your progesterone is norethistron, which is an artificial progestin. And in when you're using estradiol, you usually would use prometrium, which is a micronized progesterone, which is the body identical progesterone. So that's what Kelly said, and that's where that question comes from.
So you've got to understand there's patches that are combined with the estradiol and a progestin in them together, and there are other patches which are just estradiol. So when I was talking about the increase in breast cancer risk being with a patch, I meant the combined patch that has the synthetic progestin in it. So that's why I was saying it's an okay sort of convenient starter product, because women don't have to do two separate things. They don't have to do a patch and the prometrium or the Mirena. They've got both things together in the patch. They've got their estrogen and their progestin together in the patch. But the type of progestin in the combined patch, as Lynda said, is one of the older ones that over long-term use can slightly increase breast cancer risk. So with the patches and gels, if your question is relating to how you use them, the difference comes down to a couple of things: whether a woman likes doing something every day, like putting a gel on her arms every day, or whether she likes the convenience of just wearing a patch and just changing it over twice a week, whether she doesn't like having something on her skin. So some women don't like a visible, you know, stigmata of their menopause, you know, that's there for all the world to see. Mind you, I hide mine under my underpants, so nobody gets to see that very much. Or, you know, some women get a rash from their patches, and then they have to go on and swap to a gel because they find that they get a rash, just like some ladies get from their Band-Aids. So, yeah, it really comes down to personal preference, but they're equally effective. Some women swear that the gel works better for them than the patch, and maybe that's true. Different kind of pharmacodynamics and different things to do with their skin and absorption rates, perhaps. I don't know.
Interesting. Can you explain normal bleeding patterns to be expected on women started on both sequential and continuous MHT? And what point do we worry and start to investigate?
Oh, you take that one, Kelly, because it's a hard one.
So on both sequential and continuous MHT, the bottom line is that when they start MHT for the first time, it's really, really common in the first 6 months of a new MHT regimen to get changes in your bleeding pattern. So if you've been not having any bleeding, if you've been postmenopausal for ages, it's not uncommon that when they start MHT that they'll describe new bleeding coming. Also that they might have had really light periods before and that they get heavier on the MHT, or that they get lighter on the MHT. And this comes down to that variability between women and how their own individual bodies react to the different hormonal products. There are some like synthetic progestins that are more potent at thinning the lining of the uterus down. So the synthetic ones tend to do that better than progesterone, for example, than natural progesterone. So, you know, it really depends on the person and what product they're taking. But yes, it's not uncommon to get bleeding changes, and usually that signals that you need to change something. Often if it's just when they first start and it's just little minor bits of bleeding or a minor blip in their bleeding pattern, you might find that actually settles over time. But if it doesn't, it might mean that you need to give them a stronger progestogen or more of the progesterone, or that they might need a Mirena. But certainly if they have a persistent change in their bleeding pattern, they should be investigated at least with a pelvic ultrasound to rule out, you know, something else going on as well.
Very good. And when do you switch someone from cyclical to continuous HRT in a well-controlled lady?
Mm-hmm.
Well, it depends where they were in their perimenopausal phase when you started them. So if they were early perimenopausal, you'd be pretty brave to try and switch them after a year. But if they were late perimenopausal, you could try switching them after a year. And if you get unscheduled bleeding, or you could persist for, you know, a couple of months and just see whether the bleeding settled. But if it keeps going, you'll have to go back to cyclical. So you can have a bit of trial and error. But yeah, I think about 50, you know, I don't know. What do you do, Kelly?
Yeah, it depends on what they're using. You get, obviously, in the perimenopause space, you get everything from super regular periods to completely unpredictable, and it can be really difficult if you've told the woman that she's supposed to take her Prometrium on days 15 to 26 each cycle. She'd be constantly ringing you up going, what do I do now? What do I do now? What do I do now? So, you know, the bottom line is that there's a specified amount of progesterone or progestin that has to be given for any particular dose of estrogen that's said to be safe to balance it out and provide adequate endometrial protection. So as long as you're sticking to that overall amount, I think it's fine. What I sometimes do is, you know, well, if they're really getting erratic bleeding and we can't get to the bottom of it, sometimes a Mirena is the solution. If I can't, you know, manage with them to sort out the timing of Prometrium, which is the micronized progesterone, sometimes I'll get them to use it semi-continuously and just be reactive to their own body. So I'll just tell them, just take it 1 capsule every night, and if a period comes, take a break for 5 nights and then restart. You know, sometimes that's a lot easier for them to manage, because then overall they're getting a safe level of Prometrium for endometrial protection, but, you know, and they just take a break when their period comes. So yeah. I think that can be, you know, a bit easier for some people. In fact, just on the Prometrium thing, Stephanie's just asked, can she clarify the vaginal use of Prometrium on alternate nights with transdermal estrogen? Yes, that's true. So basically what I was saying was that if you've got a woman who's getting unpleasant hormonal side effects from using oral Prometrium, if she's getting bloating, nausea, breast tenderness, reflux, whatever, she can swap to using it vaginally. So if she was normally using 1 capsule a night, she could go to using 1 capsule vaginally every second night. So you basically can start with half of the usual amount if they're using it vaginally, because it's so much better absorbed vaginally. If they're using cyclically, so if they would normally be using 2 capsules in the second half of the cycle cyclically, she could go to using 1 capsule vaginally every night for the second half of the cycle instead. But that is an off-label use, you know, so it's accepted, but it's not TGA approved. Yes. Mm-hmm.
Fantastic. We'll just take a couple more questions because we're now at 8:30, so we've got lots of questions here. But my knowledge was that combined MHT has the slight increased breast cancer risk after 5 years, regardless of the method of delivery.
Yeah, I would agree with that. Yeah, so whether it's transdermal or oral. So with oral estrogen, you've got if you take it orally, you've got double the risk of clots. So that's where the big, that's very different to transdermal estrogen. But with breast cancer, I haven't seen anywhere that differentiated out oral and transdermal.
No, it doesn't make any difference how the estrogen is delivered. It's all the only evidence that I know of any increase in breast cancer risk after 5 years of use is totally associated with the progestin, which is the synthetic form of progesterone, specifically medroxyprogesterone acetate and norethisterone.
Yeah, because that's what all the trials were done on. So they'll have to be, I think they're redoing them. They're relooking at a lot of that data. Well, they have to relook at data, natural progesterones.
Yeah.
Fantastic. I think the last comment that we will end on is thank you for raising this issue. I see women disadvantaged in the workplace due to peri and menopause through brain fog and other symptoms that mean they go from high flyers to losing their confidence.
Absolutely. Yeah. And, as GPs, we are in such a great position to be able to help these women at a really key time in their life. So, perimenopause is a golden time because we know that their physiology is going to change enormously. Their heart disease risk is going to rise and their bone density is going to drop postmenopausally. So if we can help encourage them to do small, little sustainable changes in their lifestyle, to do these things like getting their weight under control before they start getting their cardiovascular risk factors managed, amplify that out over decades, and you're making the biggest difference to, their risk of morbidity and mortality in their 70s and 80s. It's incredible. So it really is just a huge unmissed opportunity if we're not harnessing that.
And Kelly, that's from our point of view. So that's from the medical point of view, but there's a whole other point of view, the social point of view.
Yeah.
So I actually think it's a bit of a human rights issue about how women are treated in the workplace in the menopausal state. So I've had women, I wasn't always interested in menopause, it sort of developed, but I had a woman who could not do her very high up job because of her hot flushes, and the GP had said that she just had to kind of get on with it. And she just couldn't do it. And she was in a male-dominated, area, had to wear a certain type of uniform, very high up. She said, I can't work. It's just unacceptable. And the clothing she had to wear was unreasonable for a perimenopausal woman. So I think there's, it's great that and that is the core of what I like to do is, to improve people well. That's what I tell the patients. But there's a whole other social aspect that's kind of not being addressed, and it's I don't know why it's like that, but it is.
Well, I think it's changing though, with television shows like that 60 Minutes one recently and everything, it's really raising awareness. So women are becoming more aware. They're talking about it. They're going, how come, no one's telling us this stuff? How come no one's offering us these treatments? They're demanding answers. And that's, I think, one of the reasons why, so many GPs have come along tonight to learn more about it, because I think women are asking them these questions. And we're all going to need to know about it. And, the half of us that are female are going to go through it. So, it's great to be forewarned, forearmed, and have something to offer them when they come with their questions.
Yeah, true. Yeah. Try menopause hot flushes and PPE. Well.
Oh, no. It's the worst, isn't it?
My heart goes out to you.
Oh, my goodness.
Fantastic. Look, thank you so much for all of your information. I think we've had a great turnout. We've had so many people be involved in the chat. And just to let everybody know that you will receive an email with a link to put your details down if you're interested in any further masterclasses. And we have also got a really useful download for you to go through all of that information. And there's a lot of links in there that can give you access access to further resources if you need it. And look, please reach out to WellFem at hello at wellfem.com.au. And if you've got any questions, I'm sure that Kelly and Linda and Katie, who wasn't able to join us this evening, would gladly answer some questions and certainly help you with your patients as well. So we'd definitely love to hear from you.
Absolutely. Thanks for coming along, everyone.
Thanks.
Fantastic.
Thanks for your lovely comments. They're beautiful. Thanks very much.
It's really nice to see. Have a great evening, everyone. Really appreciate your time this evening. Thanks very much. Have a great evening. Bye, everybody.
Bye. Bye.